Right, I have got the privilege of talking to you about cartilage, which is the second thing I enjoy doing most in my practice. The first is premal.
This is premal.
BTB ACL. Right. Who wants to have a crack at telling me what this is? Martinique, I only know a few names, so I know yours. So what do you see here?
Femorocondyle helps you well.
What is it, first of all? What is it, as in the actual picture I'm showing you?
I'd like to see more of the medial lateral side to the battery. This is actually a
Okay, if you take a step back, if you're showing this in a Viva and said to me, what do you see? How would you approach this as your Viva question?
This is a arthroscopic picture with the femoral joint in view and a picture of a meniscus. Surfaces on both the tibia side and the femoral side.
Perfect. Now, if you remember Piyush's talk, let's imagine this is not a tight compartment. If it's a lateral, what would you potentially be able to see that would give you a clue that this is a lateral medial side? Popliteus. So yeah, sometimes lateral sides are quite loose. When the knee's flexed in, you'll see popliteus coming down just around. Again, marker. So you'd see it just across that area there with it. Popliteus comes across down there with it. We can't see that here, so we'll assume it's medial. But I appreciate your point that we don't know what is medial lateral side. But this is the kind of stuff you get. You get a starter question in the Viva that says to you, tell me what you see. And you need to have a nice little patter to be able to start the question and say what's going to happen. So my next question is going to be, well, what is cartilage? So, Ernest, I asked you too many questions before meeting. Esther, what's cartilage? Okay. Anything else? Next one. I've got your name.
Hi, Jess. Yes, it's a substance that lines articular surface of joint. 80% extracellular matrix. And it's made up of type 1 collagen, peptide-glycan, and chondrocytes.
Okay. Adam, advances?
Articulation of the joint, it's got properties that allow weight transfer.
Okay, good. So we're building a nice little answer here now with it. So this is my tip to you. Whenever you get a question, which is what is bone, cartilage, meniscus, anything with it, you always start off with this sentence. It's a highly specialized connective tissue which functions to, and then you bang out what the functions of that structure is. So for the meniscus, we talked about load distribution, we talked about joint congruency. In cartilage, it's all about decreasing friction, distributing load, and to protect joint surfaces. When you get asked, that's your initial sentence, because it's your way to structure your answer going forward. If you have that in your mind for any sort of tissue product, then that way you've got the first 10 seconds to spurt that out, to then think about the next thing. So the next thing I thought that this is actually Richard Dere's idea of how to sort of structure your answers. You then talk about the structure itself, macroscopic and microscopic. So what's the macroscopic composition of cartilage? It's mainly water. It's got collagen. What type of collagen is it?
One or
Type 2.
1 or 2. Okay, well, you know. In the exam, I'm going to say to you, okay, well, which one is it then? Which one is it?
the hairline and articular cartilage is type 2 collagen. Fibrocartilage is type 1.
So the way to remember it, that's what my old boss taught me in Basildon, was anything that's dry is type 1 collagen. Bone, ligaments, they're type 1. Anything that's wet, like articular cartilage, it's type 2. Collagen, proteoglycan, cells, all these things, you can go further into it. Now, as soon as someone mentions to you what is cartilage, what's the first thing you want to be able to do if you've got your paper there in front of you? Draw. What would you draw?
Right now, nothing.
Who is peri-exam apart from Ernest? What's your name?
Amen.
Mohammed. So tell me about the structure of cartilage. What would you be drawing that's going to get me
I'll draw-
excited about you knowing what it is?
Yeah, so five layers. So starting from deep, so bone, then capsule, then tight.
Capsule?
Yeah, not the the fibrous layer.
Okay, I normally work superficial to deep, but you can go deep upwards, but you might get more confused. But
So bone, then the fibrous layer, then the tide mark area, then the deep cartilage layer, and then the superficial layer.
okay, and tell me about the structures within that is going to make me understand, you know.
So the superficial one has collagen fibers parallel to the cartilage.
Yep.
In line with the cartilage, and it has got a higher concentration of proteoglycans and low concentration of water molecules in it. Then you go deeper,
Low concentration,
low water.
low water superficially. Is that right? When you bounce your probe on cartilage, is it spongy or is it hard? Quite soft, isn't it?
Spongy,
So it's
yeah.
normally very water heavy at the top. Yeah?
Yeah.
Okay.
And then the deeper layer has got more proteoglycans, which is the most compressive, which bears the compressive forces, and
Proteoglycans do, or what? Or
proteoglycans and aggregants in the
what takes the biggest compressive load in structural cartilage? Is it?
collagen. Yeah.
Collagen.
Collagen takes.
And
Yeah.
how are the collagen fibers arranged then?
So vertical. So orthogonal to the line of the cartilage.
Yeah. Okay, I'm going to stop berating you now. Okay. I didn't actually plan to do this. I was going to just give you a talk, but Mr. Gupta said hammer them, so I'm going to. So this is your histological diagram. Now, the way to think about this, I mean, the first thing you want to do is draw up this. Okay, these are called the arcades of Benninghoff. Okay, these are the way that the cartilage fibers are lined up. So the first thing you do, you draw your layers, superficial, your tide mark, your deep layers, and then you draw these arcades. And this just demonstrates how those type 2 collagen fibers are laid. So as Mohammed said, they first start off very parallel to the surface. What's the purpose of that?
And
To reduce the friction.
So shear.
To avoid shear forces and going across there with it. Then you get them more radially aligned this way with it. So what happens then? What's it stopping then?
Compression.
More compressive, it becomes more vertical. So as you go further down, you get these nice vertical lines. So that's how the collagen is functioning. So the way to think about it is split it up. Don't rush into everything in one layer. I'd suggest thinking about each product in the cartilage layer one by one and then working through with it. So collagen, that's how the fibers work. That's how they work individually each layers. Water, it's very heavy at the top and it gets very hydrophilic further down because that's how collagen works. It helps distribute the load by being spongy at the top and it gets further down. The reason that happens is you get proteoglycans. Those are very hydrophilic molecules. So wherever there's more proteoglycans, there's normally less water because it pushes it away from them. Chondrocytes, these are important, right? They're the building blocks of cartilage. How are they arranged in the structure of cartilage? I'll give you a clue, it's just like collagen. They're normally very small and fat around here, very flat, so that they, once again, help distribute the shear forces behind it. They then become more circular, become more columnar, and once again, all together, you can see them down here on this slide. They form these nice columns that still replicate the whole compressive forces within it. Why is this tide mark important? What is one of the key things about cartilage that we struggle with, which is why we struggle with treating it?
It's avascular.
It's avascular, it's a neural, and it's alymphatic. Okay? So how does it get blood supply? Go on, Ernest.
It's diffusion through the subchondral layers, isn't it? Going upwards.
Yeah, so you get diffusion from there and you get small vessels coming through the subchondral bone as well with it. But essentially, this is kind of dead tissue, okay, that has no nerve endings, no blood supply. So a lot of it's coming from that synovial fluid that gets distributed across the joint surface. Now, I would love to go through the physiology of how all this works, but I haven't got time today. So let's have a read about this. It's actually very hard to understand, and I think I've learned it the week before my exam, but just have a quick read of lubrication and wear. It's quite important because, as you know, cartilage is a very important part of our body. There's loads of studies to tells you how it functions. If you have too much load that goes through the knee joint, you get decreased thickness of cartilage. That's what runners get really bad knees. You get loss of proteoglycans. Once again, if you have no load through at all, it gets very thin and starts losing the proteoglycan side of it. So actually, if you don't use it, you lose it. So moderate type of activity on it is what gives you the sort of optimum nature of giving you good cartilage around it. Osteoarthritis. It's such a misnomer because when you see patients come to clinic, they always say, I've got wear and tear, my knee, I've got arthritis with it. But we all know that isn't arthritis. Arthritis is a progressive joint disease that affects the functional integrity of articular cartilage. And that is the key thing about arthritis, is that it's damaging cartilage, which gets bone exposed, and that's why they get pain, because the subchondral bone that's exposed with nerve endings is what causes pain. I would go through all this with you guys and sort of quiz you with it, but there's a nice little table in Orthopaedic. A very classic question that I can ask you in the exam is, tell me the differences between articular cartilage and aging. And the key difference here really is the fact that in aging, they get a lot of dehydration, they lose a lot of water, whereas arthritis, they get a lot of inflammatory processes. So they get these cytokines, the TNF alphas that come along, they produce more cells to get there. You have to get more cells to the area, you need to get more fluid in there, so they get increased water in that same area. That's why they develop cysts around that area. It's a very stiff construct with aging, whereas in arthritis, it's a very decreased, more elastic kind of stress side of it. There's a nice little table which you can screenshot if you want to show you what the difference between the two of them are. Now, this is what we're kind of really talking about, cartilage defects. Who knows what this grading system's called? Outer bridge. So talk me through it. What do you see here?
So grade 0 is healthy, normal cartilage. Grade 1 is where there's on. Grade 2, you get this crab meat, like partial.
What are they called? Fibrillations. Yep.
Okay. And it's like less than 1.5 centimeters in diameter. Grade 3 is then greater than that diameter, and then grade 4 is complete.
Grade D, you also get some subchondral thinning, but then grade 4, you've got bone exposed, like you see over here with it. Has anybody had the privilege of scoping a kid at all? Their cartilage is beautiful. It's I remember with Pete Thompson, we scoped a 2-year-old, a very unusual case, but it's the most beautiful thing you ever see, this beautiful white cartilage all the way around with it. You never see this as often with it, but that's a picture of a kid's knee. So this is what we're going to talk about, is focal cartilage defects. Now, how do you manage it? Now, this is the soft tissue knee mantra. Okay, this is how you assess and manage everything. Alignment, stability, meniscus, and then cartilage. Why is that important? What if I repair this chap's articular defect on the medial condyle, but he's in massive varus? Yeah. So the way I describe to patients is like tyres with the axis. If your axis of the tyres is off, and you keep changing the tyre again and again, it's going to wear out again and again all the way through.
Sorry, that's me. I didn't.
That's my talk there.
It's competition now.
What do I do?
Just click the round button.
So when you're assessing patients, the first thing you have to do is take history, obviously, and then examine them. And the way to examine them, and this is something that gets under-taught a lot, is you look at their alignment. It's the first thing I look at, and if Primal can vouch for this, it's you look at them straight away and see, are they varus or are they valgus? Because that's one thing that will determine how you manage them going forward. If they've got a massive defect within their knee, they've got a torn ACL, but they're in massive varus, you may think about what things are going on differently inside your head. You can't really fix a cartilage defect without making sure the ligaments are intact. It's a bit like we talked about earlier with the meniscus in kids. If their ACL is torn and you're going to fix the meniscus, they're going to keep trashing it again and again because there's still that stability going inside the knee. Similarly, if you're going to fix the cartilage defect but there's no meniscus around it, there's no protection behind it. So there's no joint congruity, there's no protection. So once again, it's another area where it's going to get damaged. So only then do you go through all these 3 or 4 things. And that's why you see all these soft tissue knee surgeons that do these massive procedures where they'll do a HTO with a revision ACL, with a transplant, and then a cartilage repair, because none of it works without the first 3 things. So that is your mantra for every single management case for soft tissue knee surgery. Now, I'm not going to go into the assessment of cartilage defects because a lot of the history comes from that, but also the examination will come from earlier. But these are the broad options of how we can repair it. If you've got somebody with trauma, you want to repair it straight away. There are other options about how to manage them with injections. I haven't gone into that too much detail. You've got microfracture, oats, which is, I'll come to all these things actually, one by one actually. The thing with cartilage surgery is that you can do anything you want. Okay? You want to pick your favorite golf ball, and that is what most people do because there's evidence that supports every single case, but actually it's whatever you've been trained in and that you think it works best in your hands, because something that I've done fellowship is very different to what other people have done fellowship. So it depends on how you manage those, but there are some good evidence, which we'll go into, which I think is advocated, but we live in a society where you can't fund it in the NHS a lot of the time. But something that we can unanimously agree on is your own cartilage is the best cartilage. If it's ripped off, you should do everything you can to try and put it back, especially in young people. What can you guys see here? What I see? Pretty sure I did this case when you were here. What's the center image show?
Actual MRI scan.
Is it a defect? Not a fracture. Where is it off and what is it? What can you see?
Looks like
It does, yeah. So this is why this picture's not a very good picture, because I've shown you a picture of a femoral condyle being fixed versus a patella, but I didn't save the picture of the MRI of that one, so I can only show you different ones. But this is a massive fragment of the medial patella facet that's come off here, and you can see that is a huge chunk of cartilage and bone that came off with it. And this is a lovely case that I actually did a fellowship that we fixed back. But this is an example of a young kid again who had a massive osteochondral fracture from a dislocation of the patella, which we fixed back. And I've seen a lot of people who post things on social media and stuff about how they've done different fancy things with it. But actually, the best cartilage you can do is fixing your own cartilage. If that wears away, it doesn't work, then you've got other options as well. So I advocate everyone to be able to learn to fix these in different ways. And I'm sure Mr. Gupta will come to that in his dislocation talk. Something that everyone does is chondroplasty. What does chondroplasty mean? It's basically tidying up these smooth edges. It's something that people obviously get to do a lot with. This is why arthroscopy used to be a big ticket item back in the day privately, because you could charge £1,000 to do a quick tidy up with it. But now it's become a lot cheaper because everyone does it. But there are different ways of doing it. You can do it with radiofrequency or mechanical shaving. How does an RF probe work? You guys know? Who's used an RF probe? Radiofrequency probe, a werewolf. Do you know how it works?
No, it heats up the water around. It heats up the water around the probe.
No.
Something to do with oxidation of sodium ions or something.
Yeah, so you can only use it with sodium chloride bags, okay? The way it works is that it excitates and breaks down the covalent bonds with sodium chloride to cause free radicals. That then produces heat, which then gives you that thermal energy that reduces it back down. And that's why the werewolf's a really good item, because it only works. If you don't know how to use it and use it freehand without any water involved, you can break the werewolf device with it. Evidence has shown that it does work really well. So the way, I mean, I know you talked, you said about it dehydrates it, but it does shrink it back down slightly with it, which is why it's quite a nice item to be able to tidy the edges up. Some people talk about it can damage chondrocytes and you can hear them screaming, but it's... I used to work for two different bosses. So Andy Williams used to always RF everything, and then Tim Spalding never did it and only used a shaver on it, because his idea was mechanical shaving is a lot better to get smoother edges. And over here you can see that they've done a nice job of smoothing it, but it leaves these sort of big dents around it, which is why the RF, in my opinion, is a nicer way of doing it. It's a useful thing to do in defects that you're not sure what to do with, to stabilize edges. You don't want to end up taking away too much of it. It doesn't work in OA, because we know that scoping at OA patients just doesn't work well. But it can be something useful to be able to do less is more scenarios. Microfracture. Who has seen a microfracture, or who has done it? Bad word nowadays. Okay. How does it work? So the whole idea is that you're probing bone tissue to then produce cells that come from the marrow. So you get these mesenchymal stem cells that come along and give you some sort of cartilage. Now, if you speak to Martin Snow, he gives a he'll lecture you to death at the bar about how this is a bad idea. And actually, he gives a very nice talk on it, and I heard him speak on Thursday about it. The thing is, microfracture has become very flawed histologically and surgically, because when you actually biopsy a lot of the tissue for microfracture, it's always fibrous tissue or fiber cartilage, and it produces the hyaline cartilage that we want it to produce. It's also quite surgically flawed, because the problem is that you're altering the subchondral bone. When you push it in, you're actually hammering it in, you're impacting the bone, which damages it, and you're potentially blocking vascular channels. You don't actually get the same kind of mesenchymal stem cells coming out from it. Now, the way that if you were to do it, they've got these nanofracture sets that Stryker do, which are very, very tiny drill holes, like 1 millimeter drill holes. Those potentially can work, but there's an idea of it causing thermal damage, which can also cause problems with vascularity. But in the short term, it can give some benefit. And Andy just published a paper talking about how it works in elite athletes, because they're the guys that you want to be able to do something very short and sharp to back on the pitch again. But in the long term, it doesn't really work very well. And I think at the moment it's being phased out a lot when it comes to as the primary option for treating cartilage injuries. An OAT procedure is an osteochondral autograft transfer. It's basically where you take a good part of the cartilage from a useless part of the knee and give it to the part that really needs it. And this is a very nice system that I started using, and I saw it recently in the Munich lab, where you have, so Arthrex do a nice system actually for it. You core out a nice bit of subchondral bone with the cartilage area from an area of the knee that doesn't really need it, and you put it in different parts of the area. It's got some great outcomes. It works for defect sizes less than 25 millimeters, I should say, not more than 25 millimeters, because the idea is that you're resurfacing a part of the knee with small areas of good cartilage. And this is called the snowman effect, where you put two cups of cartilage next to each other. And I think George Bentley did a lot of these when he was at Stanmore as a mosaicplasty. But patients which have bigger defects or older have worse outcomes, so we know that they're only worth doing in younger kind of patients. Who's heard of ACI? Right, so this is a very, very nice procedure that's popularised in oswestry. This is where I first trained actually. This is James Richardson, who was the guy that pioneered most of it and got it through the NICE approval. It is now NICE approved, where you're basically, it's a two-stage procedure. You're preparing the bed, you're taking chondrocytes away from them, you're growing it in a lab, and you're going to come back and you're going to reimplant those chondrocytes once they're ready back into the knee, and then that gives you your hyaline cartilage, because you're actually giving them chondrocytes that you've grown into with it. And this has shown one of the best outcomes when it comes to giving good cartilage. And a really good paper came out a long time ago with George Bentley's crew. Martin Snow's done a paper on it, showing that they've got great outcomes at 10 years in 80% of people. Now, there are prerequisites. You can't have had any previous repair surgery. You shouldn't have any OA damage within it. Defects should really be less than 2 centimeters squared. So this is your go-to repair method for cartilage lesions of that size. The problem is you have to do it in a cartilage center. That means referring it out, which a lot of people don't do. So you can see these cartilage injuries, you want to keep them in-house, so you'll end up doing other things potentially instead. But the gold standard for these, really, evidence shows, is that you should be giving these patients to a cartilage unit to do ACI. That was the most, I think it's the 10th most quoted paper on the BJJ in PubMed that Andy Williams tells me about. MACI is the same sort of thing, but using a matrix. You've got this sort of collagen scaffold or some sort of 3D scaffold that you end up putting over the whole ACI area to help contain it. The idea is that you've got this sort of membrane that helps contain it, to help them make it more stable and give it better incorporation. And once again, it gives you good data, almost 90% at 10 years as well. This is a newer procedure. I think I'll go into a bit more detail with this, AMIC. It's essentially a poor man's AC, where you're stimulating some of the marrow and you're covering it with a collagen matrix. The idea being that you debride the surface area, you encourage some bleeding, some stem cells to come out of it, and then you can cover it with a membrane that contains it all down. It's a one-step procedure, the advantage thing of doing it. Got good outcomes short term, and it's also been NICE approved recently as well. This is the gold standard, OCA, osteochondral allograft. The problem is you won't see many of this around here because it's really expensive. It's a big waiting list because you have to rely on a dead person with good cartilage in America to get it shipped across over here. They're about 10 grand a pop as well, so it's not really useful in the NHS because we're broke. So the only way to get this done is through research, which is what all the tertiary cartilage centres do, or if you live in America. The idea is, though, is that massive defects get covered up. You're basically taking a defect, a fresh bit of cartilage, coring out the size that you want, and filling it back inside again. And this is just replacing hyaline cartilage with hyaline cartilage. It is the gold standard for any massive size. There's different ways of how you preserve it, and then different things about fresh usage versus non-union rates, but the message here is that if we had it, we'd do it more often. I'll ignore that for now. Something that I've started using a little bit, it's called minced cartilage transfer. Basically, you get some cartilage, you mince it up, and then you inject it back inside again with some PRP. And the idea being that you're giving them their own sort of cartilage mixed in with the platelet-rich plasma, covered at the patch. It's a one-step procedure again. It doesn't apparently burn any bridges, although we're not sure about that yet with it, but architects will tell you it's meant to be the best thing since sliced bread. I've used it in a couple of scenarios where we've got an osteochondral fracture in a kid, quite an old fracture. We fixed it back like you do with a couple of screws, but I've covered the edges with the minced cartilage. And that's my indication for using it, is to an area that I would tend to leave normally, I can then fill and bridge that gap where I would normally not give it at all. Has anyone seen one of these epicelial implants? There's a big talk on it from Tim Spalding at Basque this year. It's basically for people who aren't big enough for arthroplasty, but they're too old for OCAs. It's this sort of bridge the gap between the area where you can fix them with a metal implant. We've got a case actually coming up that I think might be suitable for it. It is NICE approved again, and it's got some really good data over it for the next few years, for 10 years. There's different cell-based therapies, voodoo magic. We don't know if it works, but you know, it's something to delay them before they need the eventual referral to a centre that knows what they're doing. I mean, this is the thing, is that we are now trying to restructure how we manage cartilage defects, because at the moment, a lot of people who are doing it in DGH and stuff with it, but it's recognising what the defects are that we can try to then send off to places that can give them what the gold standard is. And we come to what the algorithm is. So this is an algorithm that I talk about how to treat it in athletes, because the idea is less is more. You don't want to be giving a professional athlete a OCA that takes them out of the year for 1 year, because the rehab's 1 year for it. But actually, this is the real picture you want to take a picture of, okay? Because this is what the evidence is based on. Is if you've got a small lesion which does not affect subchondral bone, then actually things like ACI, oats are good for small lesions. All the things down in the light colours are low evidence, but the high evidence stuff are the things that are at the top of the thing, because that's what's really showed to show that makes a big difference with it. We talked about large defects. I mean, the OCA is the best standard for it. If you've got bony attachment towards it, then you've got a bit more things you can do alongside it. But actually, it's those top 2, 3 things you can see that are the only things that really we can support ourselves to say this is what works. A quick thing on SONC, just because this is something that comes up in the exam with it. Who's seen a case of SONC in clinic at all? What's the first thing you do if you suspect somebody with SONC? Before that, if you think you've got SONC, if you see that X-ray over there on the right hand side, you've got a big defect over here with it. What's the first thing you do? Non-weight bear crutches, okay, and then get an MRI scan, because then you're trying to offload them straight away. We think it's because they've got a subchondral insufficiency fracture that then gets worse and worse with load bearing, with a bit of chondrovalacia. They may have some deficiency in the meniscus as well. The whole purpose is that they've got some impaired circulation, which leads to hypoxia, gets ischemic, causes more edema. That pressure then ends up building up and then causes more blood flow impedance, and then causes necrosis. So you do your usual stuff, history examine them, non-weight bear them, and then get their MRI scan for them. And this is the algorithm that Tim taught me of how to manage these. Small lesions, non-op, look for other reasons why they've got it. So they may need bisphosphonates, some painkillers, protect, weight bear them. Big defects that haven't collapsed quite yet, you can do these core decompressions. This is a case that we did in Coventry, where you're basically drilling the subchondral bone to encourage them to start healing and release all the growth factors within the bone, but also get rid of the edema as well. So there's nice research in Munich coming out where they're actually decompressing, they're hammering from the side, medial side of the knee, to end up extracting fluid from it and then injecting either fat or injecting PRP within the knee to help reduce inflammation within it. But if they've collapsed, well, really, you're looking at doing these options here, basically, arthroplasty. I've never seen an OCA being done for a patient because they're not old. They're normally in that category, they're too old. So I implore you to assess the patient. It's the most important part of soft tissue knee surgery, is making sure you know the history, examining them, assess their alignment, stability. Remember, cartilage treatment options, it's a shared decision-making between you and the patient. Less is always more. This is a quote that I've come up with actually now, and I'm using it in all my talks now. But it's not the incisions we create, but the decisions. That's so key when it comes to seeing these kind of cases. By the way, these pictures taken are from these meta glasses. If you guys want to get a pair, they're really useful for recording stuff. Thanks.